Good day. My name is Marc van deVelde. I'm an anesthesiologist from Belgium, and my specialization is in obstetric anesthesia. It is my great pleasure and honor to participate in your online meeting. First of all, I would like to apologize that I can't attend live in the meeting. And secondly, I would like to thank everybody in Ukraine for the massive effort you are all doing against the terrible aggression you are suffering from. And I hope this ordeal will come to an end quite quickly. I have this topic to discuss: postpartum hemorrhage management. These are my conflicts of interest, but they are not relevant. This is the outline of the lecture, and I have a short introduction. Postpartum hemorrhage is defined in different ways. Usually, when it's more than 500 to 1,000 milliliter of blood lost, we are talking postpartum hemorrhage, and severe postpartum hemorrhage when there is more than 2.5 liters of blood lost. Causes of postpartum hemorrhage are, in most cases, uterine atony, trauma of the uterine tract, retained placenta, and in a very small proportion of patients, but important for us anesthesiologists, coagulation disorders. There are worldwide 15 million cases of postpartum hemorrhage, and all over the world this causes more than 80,000 women to die, with the majority, 80%, being completely avoidable. Simple measures like the use of massage of the uterus, oxytocin drugs, the use of tranexamic acid early, and IV fluids, and re-evaluation and evaluation are very important things to improve mortality and to reduce it. And there are therefore very simple measures, and I'm going to discuss them quite quickly. You need to recognize it, and clinical signs that are important to detect postpartum hemorrhage is tachycardia and a drop in blood pressure, but that is not as quickly as you might think. Pallor, a drop of hemoglobin, oliguria, excessive volume requirements, restlessness and fear, and potentially coagulopathy. Some would say that the shock index, the ratio between heart rate and systolic blood pressure, is an important factor. It's normal when the shock index is 0.5 to 0.7. It is normal in the pregnant state up to 0.9, but it is abnormal when it's more than 0.9, and even very severely abnormal when it's more than 1. And this is an indication that there is a problem. Some would consider iron deficiency anemia a risk factor as well for bleeding. Of course, when you are anemic, you have less reserves. Most of the anemic situations in pregnancy are as a result of iron deficiency. Some say that anemia in pregnancy is physiological, and it's in many textbooks like that. This is because there is more plasma increase than there is blood cell increase. However, this physiologic anemia of pregnancy is not physiological. It indicates a significant iron deficiency problem. Anemia in pregnancy is very widespread, up to 50% of women in certain parts of the world. But in most of these women, the cause is iron deficiency. So if you can, and this is logical, because during pregnancy, your requirements for iron are significantly increased due to the increase in red blood cells, etc., and also due to the fact that you lose a lot of blood at the moment of in the peripartum period. So basically, you need more than 500 milligrams of iron during a pregnancy, and if that's not available in your body, you will become anemic. So there is basically per pregnancy 300 milligrams of deficit of iron, which you need to replace in between pregnancies or also during your next and subsequent pregnancy. Iron deficiency causes a lot of problems in mother and child, and therefore we should treat it early if possible by iron supplementation. To avoid mortality and to improve on substandard care for postpartum hemorrhage, it is important that we have very good protocols. Clear guidelines that are followed by the whole department, the whole obstetric, midwifery and anesthetic staff to avoid further complications. These protocols have been long-standing described, and this is one example which is 20 years old, but there are many other more modern protocols as well, which you can use and you can implement in your own hospital. And the FIGO recommendations, for instance, in 2022 are an example of that. Uterotonics drugs are the first line to avoid and to manage postpartum hemorrhage, since in 70% of cases, hemorrhage is a result of uterine atony. The first line are oxytocin receptor agonists with oxytocin or carbetocin. The second line are all the others I've listed here and a combination of these. I refer to two nice papers that have a nice overview on what should be given and what should be done as oxytocic drugs. Oxytocin is released from the posterior pituitary gland and it contracts the uterine smooth muscle and it causes lactation. It goes through intracellular increase in calcium, resulting in contractions. It is rapidly metabolized, and the elimination half-life of a bolus of oxytocin is very short, and the placenta helps to destroy it as well. So if you give it, you can give a bolus followed by an infusion. A bolus alone will not be enough. It has side effects, and they are listed here: nausea, vomiting, headache, flushing, hyponatremia, vasodilation, tachycardia, hypotension. And especially when you give it in a bolus, and especially when you give large boluses, this might cause significant problems. This is an example of a study investigating the side effects of oxytocin, and you see that when you inject the oxytocin, within seconds, there is a tremendous increase in cardiac output, there is a significant decrease in systemic vascular resistance, and there is a significant increase in heart rate. This might even result in ST segment abnormalities and causing even myocardial infarction, has been demonstrated in some studies. Giving a same dose as a continuous infusion over a certain period of time, in seconds, it has far less cardiovascular side effects than when you give it as a single shot bolus. So use less oxytocin and use it in a continuous infusion. And how much is less? Well, we should also remember that the oxytocin receptor is a G protein coupled receptor, and that when you stimulate it very rapidly, it will desensitize, and therefore you will need to increase your oxytocin for quite quickly as a result of prior exposure to oxytocin. So people who are having oxytocin already for several hours will have more need of oxytocin because there are less receptors available. So you can, if you do oxytocin pre-treatment in human myometrium, you will have less of an effect. So chronic use during labor and delivery might result in more problems. The oxytocin requirements for elective cesarean sections are 0.5 units as a bolus, even slightly less, but 0.5 is what most people would say. If you give this for non-elective cesarean sections as arrested labor, your initial oxytocin dose is increased to 3 international units. So what does the guideline say? The guideline says that a bolus of oxytocin should be given, it should be 1 unit to 3 units, and it should then start it in an infusion, and for an intrapartum cesarean section, it should be 3 units and higher infusion rate. This is why Lawrence Sen group and Mirinali Balki have given this nice simple rule, the rule of 3. You give 3 units in oxytocin bolus over 30 seconds. You wait for 3 minutes. If it's adequate, you give a continuous infusion of 3 units per hour. If it's inadequate, you give another 3 unit bolus. And if it's 30 seconds later, again inadequate, another 3 unit bolus. So 3 units, 3 minutes, 3 units, 3 minutes, 3 units, 3 minutes. And then you go to the second line treatment. And every time when it is effective, you start an oxytocin infusion of 3 units per hour. Carbetocin is a synthetic analog of oxytocin, an oxytocin receptor agonist, and it has a longer half-life. It has the same effects as oxytocin, but they are continued. So giving a single bolus is enough. And there is the same desensitization as described with oxytocin. So repeated doses lead to tolerance, basically. It also has a similar side effect profile, but there might be less water retention and less binding to vasopressin receptors, so it might be better in preeclamptic patients. The dose for elective cesarean section is 15 micrograms. The dose for arrested labor is 68 micrograms, meaning that the dose of 100 microgram, this was the ED95. This is in obese women, and this is the dose in non-elective labor, and this is 120 micrograms, so 15 to 120 micrograms. Usually, a dose is 100 micrograms. In the situation where we need to use carbetocin, you see what is recommended in the guideline. If you give carbetocin, there is a reduced need for additional uterotonics, and therefore it might be better than classical oxytocin. And this has been repeatedly demonstrated. So there is a reduced need for additional uterotonics in cesarean section, a reduced need for additional uterotonics in vaginal delivery, and a lower risk of postpartum blood transfusion. This is demonstrated in various studies, and it will result in better outcomes. So there is a slight superior effect, but it is a little bit more expensive as well. This is a randomized controlled trial published in the European Journal of Anesthesiology, where they compared outcomes, oxytocin versus carbetocin, and they noticed in the oxytocin group higher troponin 1 levels at 4 and 10 hours, and a similar increase in QTc effect. Then you can use second line uterotonics. They all have their side effects. It could be misoprostol, it could be ergot alkaloids, but you need to have these, and these are the doses advised in our guideline. Ergometrin has side effects and has contraindications related to the cardiovascular system, and the prostaglandins will work through these mechanisms and also have their side effects. The advantage is that there is no desensitization and the production of oxytocin receptors is increased. They have their side effects, and I don't read them out here, but bronchospasm is one of the things, and diarrhea sometimes as well. So for these oxytocins, these uterotonics, oxytocin or carbetocin are first line. Use lower doses, give them slowly, and follow them up with a continuous infusion for oxytocin. Carbetocin might be slightly better, and the second line uterotonics might be necessary if uterine tone has not been established. But do have an institutional protocol which the whole team will follow. Uterine balloon tamponade for the treatment of postpartum hemorrhage is certainly a possibility. Inserting a balloon which you inflate will give compression of the uterine wall and reduce blood loss until you can do more effective efforts, and it has been shown to be highly effective. Non-pneumatic anti-shock garments can be helpful in reducing the hemodynamic picture of the bleeding and have been tested and have been advised in the FIGO recommendations as well. More and more people are using interventional radiology to stop bleeding of the pregnant uterus. Remember that the pregnant uterus, if 2/3 of its blood comes from the internal iliac artery and 1/3 of its blood supply in the pregnancy comes from the ovarian artery. So if we want to stop bleeding of the uterus by stopping the blood supply, you should ideally try to stop the blood supply coming from the aorta above the renal arteries to make sure that both the ovarian as the internal iliac artery are blocked. Different possibilities: iliac artery balloon occlusion, aortic balloon occlusion, and arterial embolization. Arterial embolization is not the way forward. Iliac artery balloon occlusion is used, but it will not stop completely the blood loss. And aortic balloon occlusion, a REBOA, seems to be more effective. And with the aortic balloon occlusion, you will see less blood loss, less transfusion, reduced length of stay, and a lower hysterectomy rate. In patients with placental abnormalities, for instance, the risk of fetal radiation is extremely minimal if you place the balloon with radiography. What are the transfusion triggers and cell salvage? I'm not going to discuss this. They are different from institution to institution, but I would say in a young, healthy pregnant patient, an hemoglobin of 8 before you transfuse is okay. Cell salvage has no real advantage unless you have a case where you expect significant blood loss and where you can install it in a timely fashion. There are also some coagulation issues which the anesthesiologist need to understand. Important is fibrinogen. Fibrinogen is crucial in obstetric bleeding together with platelets. Therefore, tranexamic acid to stop fibrinolysis has been tested in the women's trial, and there has been a clear reduction in bleeding incidences and mortality as a result of bleeding when early tranexamic acid was given within the first 1 to 3 hours after delivery and after bleeding started. So given 1 gram of tranexamic acid repeated once at least can reduce mortality and morbidity as a result of bleeding. And therefore, in most guidelines, tranexamic acid has been recommended if there is a bleeding ongoing. Prophylactic tranexamic acid, I've not included these slides, prophylactic tranexamic acid has not been advised. A second aspect of obstetric coagulation is fibrinogen. Remember that fibrinogen levels in pregnancy increase to 4 to 6 to 8 grams per liter as opposed to 2 grams per liter in the non-pregnant population. If you have a bleeding, most clotting factors and thrombocytes stay normal for a very long time. There is a big reserve available, but fibrinogen decreases the earliest, and this is crucial to avoid problems. This is another example of blood sampling at different stages of the bleeding, and you can see that the fibrinogen quite rapidly decreases. If the fibrinogen is decreased early in the bleeding, so it's not a result of dilution or consumption, this might be an indicating that there is going to be significant postpartum hemorrhage. This is a study where they looked at early fibrinogen measurements, and those who had a fibrinogen below grams per liter had 100% predictive value, positive predictive value for bleeding, while the ones with above 4 grams per liter, there was 80% negative predictive value for bleeding, so no chance of bleeding, basically. So therefore, we would suggest in this guideline, impartially written by myself as well, that we control the fibrinogen just before delivery, and that we, once the woman is in labor, we will immediately after delivery of the baby take some blood and test it for fibrinogen as well, especially when there is a high risk for bleeding. How should we do fibrinogen testing? You could take a Klaus lab test, but it's quite slow. You need point of care testing to give you a very quick, in 5 to 10 to 15 minutes result of how high the fibrinogen is. It has been demonstrated that actual Klaus fibrinogen measurements have a clear-cut relationship with the levels of fibrinogen measured in stoichiometry or rotum, excuse me. So if you go to the FibTem A5 with the reagents to evaluate fibrinogen, you will see a very clear relationship between the level of the fibrinogen. If it's 1, there will be a very low value in the FibTem A5. But if it's 6 to 8 grams per liter, there will be a much higher FibTem A5 measurement. And this has been demonstrated in many studies, several coming from Cardiff and the Cardiff group. This also means, since you have higher fibrinogen levels in pregnancy and they are still normal, but you still are bleeding, you should not give too quickly plasma because then, of donors, because then you dilute the fibrinogen, because the plasma of donors is always lower in fibrinogen. So therefore, there will be the advice that you give fibrinogen concentrate to treat the ongoing blood loss. Fibrinogen therapy and fibrinogen concentrate are not effective if you do not have a measurement of the fibrinogen levels or the rotem. Then basically giving fibrinogen in all patients that bleed is not effective, because in many the fibrinogen will still be normal the moment you are giving it, or at almost normal. If you, however, use the FibTem A5 as an indicator, you will see improvements possible with fibrinogen concentrate. There is less fluid overloading, for instance. So it is positive. But the FibTem A5 of 15 cutoff is too high. It should be lower, 12. And with the new system and reagentia in the rotum, it should be actually 7 or 8. But if you give it in those patients with a low fibrinogen, you will see a significant improvement with your with the rotum guided algorithm in these patients. So giving fibrinogen based on the rotum is a very good idea, and should be implemented in as many as possible obstetric units. But the downside is that it's a relatively expensive test. So this is the algorithm our guideline proposed, and fibrinogen and antifibrinolytic agents are crucial in the management of these patients. Thank you very much for your attention.